Okay, big welcome. Great to see everybody this evening. And we're just waiting a few moments, let everybody jump on, and then we will get the ball rolling. And excited to see everybody here. So yeah, seeing a bunch of people commenting in the chat. Thanks for that. So just asking for everybody to let us know where you're from, what's your health profession, just to get to know you as we get the ball rolling. I'm hoping tonight is well under an hour, hopefully about 45, 50 minutes. So just to give you some kind of timeline. Dr. Teresa Adams is going to be joining me. She is one of our participants in our Functional Medicine Fast Track foundational program. She's a real superstar, and we're going to be going through some labs exactly the way we do it when we teach and go through in our Q&As. So you're going to get a real live look at exactly the way we teach, the format we use, and how we build exceptional functional medicine practitioners. Great to see a wide range of health professionals joining us this evening. So this is a great case we're going to go through. So it's actually, Teresa will fill you in as we go along, and you're going to get a lot of learning from this. We're going to go through 4 foundational functional medicine labs that we go through, and we're going to go through some timelines and go through some in-depth labs and really connect the dots. So really what we're wanting to do is to just show you the systemized approach that we use to teach our functional medicine practitioners, and for them to be able to take that functional medicine systemized approach and use that through competency and confidence to see more patients. One of the things that hold a lot of functional medicine practitioners as they start to get into functional medicine is just the doubt that they can get their patients right. So what we want to do is to really show you how we build that confidence, that competency in a short space of time. We're going to ask you if you can hold back on any questions as we go through this. If you do have any questions, please pop them into the chat and we can go from there. Here we go. There's Teresa. Teresa, welcome. Fantastic. Super cool. So we'll just wait a second or two more and then we'll get started. I've got all the labs ready. But again, just a quick introduction. Functional Medicine Fast Track is really about helping health professionals get functional medicine right. And when I say get it right as far as clinical, business, and marketing. It's not just about learning all the information in functional medicine. It's about understanding how to put this into practice and get it profitable so that you're sustainable as a functional medicine practitioner. And then the joy of functional medicine is we have the ability to support patients online too. So many of our practitioners will do this either at a hybrid level or completely online. That just gives you the ability to reach further than your local community, free up your time as well so that you can really focus on getting your patients right and making sure that you lead with a good lifestyle and the ability to have your health at the highest level. We do find that 95% of the practitioners coming into the Functional Medicine Fast Track program, we help them with their own health first. And that is often a big priority for most, is they feel like they've been let down just with the knowledge that they know. And we've got to kind of help them back on track. So Teresa, do you want to unmute there and just say a quick hi?
Hi. Hi, everybody.
How are you, Teresa? How's your day been?
Yeah, no, it's been pretty good. Mellow. More mellow than yesterday.
As the week gets started, yeah, crazy. Yeah, starting with December tomorrow.
Yes.
It's really jumping in there. So good to see everybody from all around the states. So yeah, it looks like every state that is being represented here and many health professions. So we're going to get the ball rolling now. And just want to first of all just say a big thank you to Teresa for just giving up her time to spend the evening with you guys and to be able to show exactly the way we teach at Functional Medicine Fast Track. So Teresa, you ready to rock and roll
I am.
and get started? I'm going to be busy sharing my screen, and then we're going to go through the labs and the timeline and everything that we have. We have quite a lot to go through. I'm going to conduct this session exactly the way we would do it in a live Q&A during the program. And the way we do that is going to be very interactive. I'm going to be seeing where Teresa's thinking is. As a functional medicine practitioner, it's all about the thinking process. It's not about protocols. It's about the understanding. So I'm going to be inquisitive. I'm going to find out from Teresa, where is she at? How does she understand it? Is she connecting the dots? And then I can help along the way. But I really want to be seeing how she is thinking through the process. So Teresa, let's get started. I'm going to share my screen and we can there we go. Okay, can everybody see that? Just give me a heads up in the chat if that is all visible to everybody. Thanks, Dave. Cool. Okay, so looking good there. So, and I just want to first of all compliment Teresa because she's one of our outstanding students. She has done an amazing timeline here, and she's done incredible in her business as far as fast tracking. And I'm going to ask her to give a few words at the end just to let you know how much she has done in such a short space of time, just to inspire you. Perfect. Thanks, Chris, for letting me know there. Okay, cool. So what we're starting with here is the timeline. Timeline is so critical to connect the dots with the intake form, just all the information that we gather from the patient, and really go back in their timeline, look at family history, daily stresses, triggering events, current concerns, signs and symptoms, and start to see the patient on the whole. So Teresa, do you want to maybe just give a quick summary, maybe not go through everything, but just give everybody an idea of the background as we go through here?
Is it okay? I mean, is it okay to just say it's from my, this is actually my timeline. So
Yeah, absolutely. If you're happy with that, let people know.
it's easier
That's
to
great.
not speak as a third person.
Yeah.
Okay. So essentially, I grew up in the South Bronx, and we were pretty poor and of color and all that stuff. And so my mom was very depressed and probably had like 10 children by the time she was 30, and suicidal, and that caused her to be hospitalized when I was very young, which is one of the probably the most pivotal traumatic events for me. And then my father was alcoholic, and he battered my mom, and he battered us, and he died at 40 of pancreatitis. I was 9 years old. And then I had a stepfather. So all of these things sort of led me to sort of depend on myself and not all of the crazy people, right? But it also caused me to develop a food addiction. So that's where I went to kind of keep all the feelings in place because I was so scared all the time. And the food addiction sort of led me through like, all kinds of yo-yo. My first diet, I was 5. My mom took me to the doctor, and there was pills and there was shots back then. And, we're talking about in the 60s. And there were like fish and chicken diets and all these different ways that diets were done. And I think White Watchers came out when I was around 11, and I went to that too. And I think at 11 years old, I weighed about 200 pounds. And so it became this, everything that I really was traumatized about got bucketed into my eating disorder so that I could actually feel like I had a good life in a way. It was almost like a delusional way of saying, oh, my only problem is that I have this. It just became the thing I hung everything on. I was really good at school for whatever reason. I was, the oldest of the ones that my mom did raise, which was only 4 of us. And I was good at school, and so that became the way that since nobody was educated, I thought maybe that was the problem. So, so I decided to become educated, and I literally tolerated being at home until I was 19 when I left for California on a Greyhound bus. So I had no idea. I knew I wanted to go to college, but I had no idea that I was ever going to become a doctor, and I didn't even make that decision until I was in my 30s, and I kind of piecemealed my way through college. So all of those things just like was everything about how I interacted with the world, right? Like I interacted with the world um, sort of keep all emotions in check, you know, overeating, but being really smart and very productive in the linear kind of way, even though I'm not linear, but I kind of pretended to be. So what else can I say about it? Part of it was I did have sort of, I didn't really vomit, you know, I say bulimia, but it was like I used to take laxatives. I used to fast for 4 days at a time, and then I'd eat. I'd binge eat, and I didn't know why I couldn't stop. So I was sexually abused. There was all of that as well. So it was a lot. So I came to California and I just started trying to create a life for myself. And really, I had nobody out here, but I figured something out. Um, and what else can I tell you? I had PID when I was 17, and that led to 3 ectopic pregnancies later. I couldn't get pregnant for a long time. I had my one child through IVF. That was before medical school, and so she was born right 6 months before I started medical school, which is just the way it happened. I wouldn't have planned it that way, but that's how it came out. And what else can I tell you? Oh, the other thing is that I recently was diagnosed with lung cancer. 1 year ago, this month I was diagnosed with lung cancer. They took a lobe of my right lung out. All my nodes are negative. I declined chemo. And so I've just been trying to, you know, do much more plant-based, whole foods eating than I was even before. I would say about 6 years ago, I would say when I was 40, I weighed about 300 pounds. That was in medical school. I had gastric bypass in 98. And I think it allowed me to lose 40 to 60 pounds in that area. So I ended up being about 240. So about 8 years later, I took off another 70 pounds through Weight Watchers. And then, you know, I've sort of been yo-yoing between 160 and 180 for the last few years. I've never been at what would be considered a healthy weight in my entire adult life. I do want to do that. And I want to be healthy, obviously. And so now, in terms of the lung cancer, it's going to be just monitored for the next 5 years.
Got it. Got it.
Did you make anything else out?
Yeah. No, I think it's a great summary, and it's good for people to see that this is part of functional medicine, is where we have to go back and we have to document to understand where the person is at. And, you know, the ACEs they've gone through, the adverse childhood events they've gone through, the traumatic events, the diagnoses that have popped up. These are so important. And thank you for sharing that, Teresa. Mm-hmm. I think it's just so important to be able to see and stretch out how the experiences have accumulated to where we're at now.
Yes.
And for you, a lot of those experiences have accumulated positively, which is massive. So going now just quickly to the intake form, I don't want to go through this completely, but what would you say are your main concerns at the moment?
Well, obviously, I want to get to a healthy weight, even if it's at the top of the range. I want to get to 25, a BMI of 25.
Got it. So that's the main goal.
I also want to be as healthy as I can to prevent cancer from coming back. Anything else? You know, I would like to not feel like I need to eat all the time. Like, I feel like it's not usually all morning I'm fine, but toward the evening when the transition is from work to relax, there's this need to eat for the rest of the evening.
Got it. Okay, so let's jump to the medical symptom questionnaire. Some of you may be aware of this, others not. This is a form we typically use, which we can track on a monthly basis to see just all the signs and symptoms and see whether somebody is getting better or they're not, they're plateauing, where are they at? Also, just the total gives us an idea of where their health status is at the moment. Now, for Teresa, you can see there's a lot of zeros here. This is actually a very clean report, which is really, really good. Some of the areas that are popping up will be in weight here, just as she's mentioned, with binge eating, craving certain foods, weight, compulsive eating, and then a little bit with mind. But on the whole, a little bit with skin issues here, but on the whole, it's a total of 18, which is on the good side on the whole. So this is good. And we're going to see this with a lot of patients. We'll see patients in the single digits down at 3, 4, but they've still got concerns. They still got goals. And I think this is an important concept because as functional medicine practitioners, it's not about waiting for somebody to be on death's door. It's about helping them to optimal wellness. And we have to get that paradigm right. So are we waiting for somebody to have an MSQ of 100? No, we're taking them where they're at, taking their life story, and then putting a personalized plan together in accordance with their goals. So I think just explaining this a little bit, and so there is an understanding of how we use this in functional medicine. Anything else you wanted to add there, Teresa?
I think that if I had done that 5 years ago, it would have been very different, but I've done a lot of work in the last 5 years.
Yeah, that's the amazing thing is the intuitiveness that you brought to the table over the years and already got your health into a great direction. So what we're going to start with here is the genetic panel. This is the health panel, and this is the summary table that you can see. The summary table is then divided into, let me make this a little bit smaller, into blocks or into grouping. So you'll see on the left here, lipid metabolism, methylation, detoxification, inflammation, oxidative stress, bone health, and then there's the next page, which we'll go through. So we're going to dive a little bit deeper into this. And what we want to do is to be connecting it to everything else that we see, the other labs, going back to the timeline, the current concerns, and see how we can start to connect the genetics to those. So we'll be referring back to this. Again, I'm going to throw the ball into Teresa's court and ask, okay, what are her thoughts, and see where her thinking is as a start. So Teresa, do you want to just start with the lipid panel? Just give us an idea of what you're seeing there and start from there.
I see like, I see like the high impact area being the APOE. I'm not completely clear. I think this is, I don't, it's really the size. I think, is this the size and particles of how the LDL is?
The APOE E4?
Yeah.
Or the CETP?
I'm talking about the APOE.
APOE, okay, got it. Let me just go up to this other report. So I want to show you this report because it's definitely by far the best in the market at the moment. There isn't another genetic panel. So this is the panel that is the summary of those blocks. And this report kind of pulls an algorithm together and it'll say, okay, lipid metabolism is a high priority. And it's because we've got those 3 specific SNPs there, single nucleotide polymorphisms. Methylation is also seen as a high, detoxification, moderate inflammation high, and then oxidative stress to insulin sensitivities on a low. So let's go back to that. And certainly having the APOE E4, which 75 million of 300 odd million Americans have a single APOE E4. This is coming back from caveman days when it was a good thing to upregulate inflammation. So having this nowadays, when we just have such a toxic load, a different environment, a different lifestyle, upregulating inflammation with these kind of genetics doesn't really benefit us. And the big lifestyle issues that can contribute to upregulating this specific lipid SNP is going to be saturated fat, it's going to be alcohol, and anything that's increasing inflammation with respect to eating, because the high risks are going to be cognitive decline and cardiovascular disease, particularly with the APOE E4. So that is going to dovetail a little bit with the CETP here, which is renowned for reducing HDL. That's our good cholesterol. And that is going to obviously be associated with cardiovascular disease. So that is something then we want to be thinking about. Okay, we need to do a lipogram, look at the cholesterol, see what's going on. And Teresa has done that. So I want you to connect the dots there as we go through that. PON1 is, again, it is associated with the risk of atherosclerosis and cancer, actually. So that is a genetic that, again, we need to be aware of. And you'll see in the diet panel, this is particularly related as well to the necessity to increase monounsaturated fats and fruit and veg into the diet. And that'll be part of why the diet panel summary is coming out with Mediterranean style diet. So these are very important, and that's why it was on the high level. That APOE E4, again, is a celebration when we speak to patients because it's in our control. Every SNP here is in our control because they are lifestyle related, nutrition related. So that is the big positive. So any questions there, Teresa, or did that all make sense?
That makes sense.
Perfect. Okay, so let's move to the methylation panel. And what are your thoughts here to start with?
Well, I have the moderates, the high impact SNP at the MTHFD1, and even on one of the MTHFRs, it's moderate, and the COMT is also moderate. So, I mean, this is going to impact my ability to use my B vitamins, which comes up later. And it may mean that I need to take methylated Bs, like for most of my, for the rest of my life, really, right? Because I'm not methylating it as well.
100%. So methylation, as the summary came up, as a high priority. And the reason for that is we've got these 4 specific SNPs in the panel here. So MTHFD1 is actually a choline dependent SNP. And you may want to look at just bringing in some boiled eggs, some scrambled eggs, get some choline there, but not necessarily one of the biggest priorities. MTHFR, this homozygous 1298, is a big priority. This is going to bring you down to, a 50% efficiency in this gene at least, possibly more. And that is, as you just said, the necessity for an increased amount of particularly folic acid, more than 800 micrograms, must be methylated, is going to be a necessity for life, just to get that in the zone. Now, this will dovetail with the lipid panel, as well as what we see in inflammation panel and detox. And the reason for that is methylation, the key result of methylation is going to be glutathione. So glutathione being our strongest antioxidant in our body, obviously it's also related with neurotransmitters, the urea cycle as well, but the main focus here is going to be antioxidants as far as SAMI goes and glutathione. And we'll be looking at that in organic acids. So I want everybody to bear in mind the methylation genetics here. And when we get to the organic acids, that is going to give us a part of that panel is going to tell us the glutathione status. And that's going to be related to methylation here. So that MTHFR is going to be very much methylated folic acid. Methionine receptor here is a B12 dependency, and we can test to see that in serum, and we can look at organic acids to see if there is an abundance or not. COMT gene is going to be magnesium dependent, as well as all the B vitamins. So those are going to be the key minerals and vitamins that are going to be key to test and know, like, what is your RBC magnesium? Do we need to increase that, for example?
And that comes in the oats as well.
Exactly. That's going to come in there as well. So let's have a look at detox panel. So your detox panel on the whole is pretty clean. We do have this glutathione transferase that is a little bit slow, but not necessarily one of the real big ones. Often these deletions of GSTM1 and GSTT1, those will really compromise glutathione recirculation. So that is a celebration that you have those two, and a big positive in your favor. This quinone reductase here, which is homozygous, may not be relevant at this point, but we need to be aware of it because that's going to be with respect to your 4-hydroxyestrogen. We don't have a Dutch panel, so we're not aware of what your status is as far as the 4-hydroxy. 4-hydroxy will go through phase 1 and phase 2 detoxification. Phase 2 can get caught up in a quinone abundance, which is going to be DNA damaging. So we need to be aware of this, but I think you're still in the process of doing a Dutch Plus. Is that right?
Actually, as we speak today.
Okay, there we go. So yeah, that will be more relevant to the Dutch Plus test, and we look at the 4-hydroxy and see how that is processing. But we do know that methylation is part of that detoxification pathway as well. So just going back to methylation here, we need to check the status here, make sure that you've got enough glutathione, because this is all going to be very relative to the lung cancer, and making sure that we've got everything in check as far as that ability to keep the oxidative levels down and the inflammation levels down. Okay, so let's move along then, Teresa, to the inflammation panel. What are your thoughts here?
There's nothing huge. Everything's sort of like in this moderate area.
Yeah, we got some heterozygous here. So we've got 4 or 5 of them. So the accumulation of all of those is really the problem. So you're going to have all this upregulation of inflammation just by that slowing of all of those. So really what we want to be doing is looking for markers that are inflammatory, highly sensitive CRP, ferritin, sedimentation rate, interleukin-1, interleukin-6. Try and find something that is elevated that we can use as a future biomarker, that as we put a personalized plan together, we're dropping those inflammation biomarkers. So obviously we want a clean panel here, and with the history of the lung cancer, we want to get this really optimized. So all good there. Very clean oxidative stress panel. So you don't have anything coming up here. You've got a positive catalase. So that is really, really positive. Bone health as well. So main thing here is to check your vitamin D level. You have had that done. I know it's really good. So we'll see that as we look at your labs and go through that. Insulin sensitivity, Papa Gamma. What are your thoughts around that? You're aware of that gene?
No, I'm not sure exactly what it means in terms of my insulin. I mean, my insulin sensitivity, insulin sensitivity has been a little bit of an issue, obviously, because I've had, the eating disorder.
Good, yeah, and you've done your lab, so we can have a look there. So just to give everybody some insight here, Papa Gamma is what we call a transcription factor. So it means that it influences another 200 genetics when it's upregulated. The joy with Papa Gamma is it is lifestyle dictated. So if we have our lifestyle in check, our nutrition in check, that transcription factor is down-regulated and does not switch on all those bad genes, which are going to disrupt insulin. Right. So this week, again, we can check with a patient, look at their hip waist ratio, look at their BMI, have a look at their insulin, fasting insulin, look at their fasting sugar levels, and that'll give us an indication of, is this gene being impacted or not? And so we'll have a look at Teresa's labs, and you'll see how this has not been upregulated currently. Now, it may have been different 10 years ago, but at the moment, it's actually down-regulated. So we do have a caffeine sensitivity. That means that caffeine will detoxify very slowly. Do you drink caffeine, Teresa, or is that not in your diet?
I have been drinking caffeine since I could drink a bottle. My grandmother put espresso in my milk in my bottle.
Okay.
So I think I have had caffeine my entire life. I don't even know if I may have spent a day or two without it. Mostly I drink it in the morning. It's sort of been a habit my entire life. I could drink it at night and go right to sleep. So it's not like I feel it in that sense. So I don't know. This is an interesting one, I think. I saw it too. I was like, that's interesting.
Yeah, and there is kind of a threshold for everybody, and it depends how blocked your detox pathways are already. So the research shows that 300 milligrams is where it starts to affect the cardiovascular system. And this is heterozygous. You may be tolerating more, and the coffee that you're having may not be a very strong caffeine. So that may be why you can have it in the evening and you can sleep.
Nobody that lives around me would agree with that. They're like, oh, she makes the strong coffee. Anyway.
Strong coffee.
Yeah. I'm a Pete's coffee drinker. Some people from California would know that. But that
Okay.
is. So.
Okay. You don't have any blood pressure issues?
Nope, never have. It's always been pretty low.
All
My
great.
heart rate is also low. I can't explain that either. I've had low heart rate, low blood pressure.
Great. Okay. So salt sensitivity would be relevant if there was some blood pressure issues. So you'd retain salt a lot easier, increase blood volume, and that could have an effect on blood.
I don't have a need to eat salt. I don't feel like I'm attracted to salt at all. I don't like want to eat salt on all my food, or I don't have that.
Great. Great. Bitter taster. So do you shy away from cruciferous foods?
Can't stand it. Oh no, I actually eat cruciferous food mainly because I know I need it. I make smoothies and I use fruit to help me do it. But I do a lot of cruciferous vegetables, but I don't like bitter taste at all.
Okay, so that's relevant there. Okay, and then you got the lactose intolerance and your gluten intolerance here. Was that something new to you, or is that something that now you have to?
The gluten intolerance surprised me. I mean, it kind of has me think that I could have a tendency towards celiac disease, right? And so I was like, oh, that's surprising. But I haven't been a bread eater for years now, for at least, since I lost the second round of weight. So it's been at least 10 years since I've had it. But I mean, it's not even in my diet at this point.
Well, that's great. That's
on holidays. Like the holidays, I might have something, but I don't even eat it anymore.
Okay, great. So let's remember that. So as we go through labs, this may be relevant as well, and go from there. So let me see if I can switch to the new one. Or the next one's under all these tabs. Okay, I've got the labs here. So let's run through the labs. So going back to the lipid panel, and in the genetics, we want to do a lipogram and have a look here. So you'll see cholesterol is looking good. We do have a little bit of higher LDL, and it's always worthwhile looking if this is oxidized or not. So obviously we want to get this into check. It's certainly not extreme, and that's certainly a sign that you've got your nutrition in check, got your lifestyle in check, and that's all good. A couple of things to point out when we did look at the inflammation panel, that was pretty high. It was a moderate. Your highly sensitive CRP is coming up 0.3, which is excellent. So again, a representation that your MSQ at 18, just what you're telling us, you've brought your weight down from 300 pounds down to 175. You're getting a lot of things in place here. You're not switching on those genetics negatively. You're actually bringing a lot of factors into positive play. Let's see what else is relevant. Homocysteine. So this is now an interesting one. So we've got homocysteine at 7. That is ideal. It should be between 6 to 8. However, homocysteine can be a little bit offsetting. We need to look at other factors as well. We'll look at organic acids. That'll give us a deeper understanding if methylation is working properly. But on the whole, homocysteine at 7 is great because it can be oxidative as well.
My last one on my previous lab, it was 5 even. So it's gone up actually a little bit.
Okay, which is a positive. So we don't actually want it dropping. So we want it at a mid-level, but it can be misperception of being good. I've seen that many times. Glucose 98, so that's all good. You've got this protein that is on the low side, and we're going to connect some dots here when we go through the stool sample. And Teresa will tell you exactly why this is on the low side.
Yes.
And how we address
now, or
that.
You want me to wait?
Yeah, when we get there. So
okay.
If everybody can just remember this low protein that's come up in the labs, this is why it's important to do labs, do blood serum, and just go through a lot of these. A little bit of
my
liver.
Last one, it was 6.0, so it has gone down too, the protein.
On down a little bit, okay.
Even more.
We need to be addressing that. Okay, so you are taking some thyroid medication, is that right?
Yes, and I'm on 120 of NP. This is the first time I've seen it look like this, though. It's been usually pretty. I don't. That this surprised me actually. And I think I'm taking a pretty high dose, but there's been a lot of issues with the medications not being the right dose that we think it is. So I don't want to take that face value. I just want to do it on a retest, because
Yeah.
I've never seen it look like that.
Okay. Okay. And that's important as well, just to have a timeline and know, okay, is this something odd? And do we need further investigation and have a look at it more regularly? Can I ask you, Teresa, these antibodies, are these coming down or these going up, staying the same? Where
I
are these at?
actually thought they were coming down, but when I looked at the last one, and when I say last one, it's probably 6 months prior. Um,
Right.
the they were right around the same. I think it was 46, and
Similar.
it was right around the same. They
Okay.
haven't gotten a whole lot better.
Okay. So the one thing to just think about here is maybe that genetic panel with a gluten intolerance. And we may need to just cut out gluten completely
Hmm.
and see, and the dairy, and just see how that affects these antibodies as well, because we know that they do very much associate with them. So yeah, that might be why it's kind of plateaued. You probably found it has dropped and now it's kind of sitting there and there's
Yes.
something that's all just irritating it. And it may be something as simple as that because we've got those genetics in there.
Hmm.
So we do have some sulfate on the higher level. Do you take any
Oh yeah,
DHEA?
I take 25.
Okay.
I just changed it to every other day instead of every day.
Okay, so you're doing some adjusting there. And again, good to do that and see. We do have a cortisol on the high end here, but it'll be good to do a Dutch plus. So when those results come in, it'll be good to see what is coming up. Let me see if I can get to, it's under all my tabs here. Damn, I can't get to the, the one that's hidden.
I tried to label them, I think.
It's there. It's just got the Zoom tabs here, and I can't get
Oh
to
yeah, I
the
got you. I know.
genetics, the diet panel. I want to get to the diet panel, but I can't get there. Okay, so let's go to the stool analysis and start here. So this is pretty interesting. Give us your take, Teresa, and your understanding of the stool analysis.
Well, good to know there's no dysbiotic flora, but lactobacillus is pretty low. Um, I tend to have the sense that the lactobacillus is almost more important than the other ones that are low, like enterococcus and, well, bifidobacteria, we need it higher also. Um, but then also when you come over to the commensals, the strep is on the higher side. I usually am picking 3+ and up. Are you also do you also consider too high?
Yeah, and that is all. We need to understand the limitations of certain tests as well. So what we want to look at is the overall picture here.
Okay.
And knowing that 90% of the time with functional medicine patients, we're going to be starting with the gut. So what we're looking at here is, first of all, if there's 2 or more in the commensal bacteria, we have dysbiosis. So first thing is, by definition, we're working with some dysbiosis. So even with your MSQ down at 18, on the whole, you don't have any major concerns. We're finding some dysbiosis. And this is pretty common. So we can see really healthy people, but still having this gut dysbiosis. So this is why it's important to do a stool analysis, even if you're doing it on an annual basis, and just see what is happening. So as you pointed out, yes, beneficial bacteria is certainly on the low side here, and we want these all on the 4. Ideally, we have nothing in the commensal, and it's great that we don't have anything in the dysbiotic. The limitation here is when we don't have anything dysbiotic, they're not going to culture anything out and put antimicrobials through them. So we will have to do a little bit of guesswork on which antimicrobials to use in this instance. So we do have an abundance of the imbalanced commensal flora. So we're going to choose something that's pretty broad-banded, something like Designs for Health GI Microbics, or we'll use Biobotanicals Biocide, an advanced formula, something with a good combination of antimicrobials. We may even add in some candicidal, some zymogen candicidal, or even some Argentine silver, and just make sure that we're not leaving anything out there. Do that for 3 weeks. They're pretty gentle, and we'll slowly rebuild the microbiome.
Oh, you said for 3 weeks? I'm always thinking 3 months.
Sorry, 3 months. Did I say 3 weeks?
Okay.
3 months,
Yeah.
12 weeks, 12 weeks for sure.
Okay.
So we'll come back to whether we're starting with probiotics, certainly starting with spore probiotics. So megaspore, that might be microbiome labs, might be a good option to start, but we're going to discuss a little bit of SIBO as we go to organic acids here. And we wouldn't start with probiotics for a reason that we'll explain to everybody as we move along. So here we're having a look for viruses, pathogens, parasites, everything's coming up here. That does not mean that there aren't any parasites. So parasites are very hard to detect, and we almost have to assume that 60% of people do have parasites. And as we go through our functional medicine protocols, if you want to call that, we need to bring in antiparasites at some point. So here comes our first little red flag that's going to pop up. And I've got to really stream down here. Okay, so whoops. Okay, so Teresa, tell me, what are you seeing with this panel?
So obviously my elastase is very, very low. And that's a result of the bypass I had in 98. And so essentially, like my stomach is not producing acid because of the way that it was cut off in the area where the outflow is. And because of that, then the small gut does not see the acid and the food coming through, so it does not release the elastase, or it doesn't release any of the enzymes from the pancreas. So that's happening, which then also leads to issues around protein absorption or protein breakdown even, and also puts me at risk for SIBO. And I think I mentioned that if I had this to do over, I wouldn't. Right?
Yeah.
Right? Because I still had to do all the work, and it really didn't work very well to begin with. You know, I still ended up living at 240 to 260 pounds, but nonetheless, I'm not gonna let them go in and fix it either, because that's risky too.
Excellent, excellent. So I hope everybody understood that elastase is a pancreatic function here, and because of the gastric bypass, that has almost just been negated because it's not getting the stimulus from the acidic chyme going into the small intestines. The pancreas has almost been switched off here. So that's going to bring a need for pancreatic enzymes, and that is something Teresa needs to bring in, along with anything else that's going to help to digest food, bile acids, etc. What are your thoughts on the secondary IgA here?
This is a thought that came up after us talking about it, but there's a part of me that thinks that my protein is low enough that it may be even affecting my ability to produce antibodies.
Yeah.
And I think it's affecting other things too. You know, hair loss, I think, may be associated with it. So one of the things besides doing the hydrochloric acid and the enzymes, I'm also now adding in free-form amino acids to see if I can boost this up.
Yeah, I think it's a very important point to think about that low protein. We know that protein digestion is going to start from the stomach, and it's worthwhile, you know, as we age as well, we're going to get less hydrochloric acid, less pepsin. So you want to be testing stomach acidity and just having a look and seeing, do I need to add extra betaine hydrochloride, extra digestive enzymes, so that you can break down that protein that you are ingesting. And certainly that connection back to the immune system, you may not have enough protein just to build that up. So secondary IgA is obviously complex. It's our main immune system, or 85% of our immune system on all the mucous surface areas. And it's going to be pretty indicative of low-grade chronic stress over a long period of time that has depleted the immune system. So one way that you want to look at just restoring this is obviously addressing all the underlying external stresses and internal stresses, but at the same time, you can actually give the body immunoglobulins. So we'd give them IgGs, we'll give them IgYs, and just support the immune system rather than letting it try and battle its way up. Having a look at short chain fatty acids, what are your thoughts here?
Well, the butyrate is low, which has to do with the dysbiosis, which has to do with low, I want to say low lactic, not like I'm not thinking of the word. One of the microbiome parts that were low. The lactobacillus, that's what I was trying to say.
Correct. Lactobacillus has got a big part to play with respect to building up particularly butyrate and the short-chain fatty acids. Short-chain fatty acids are obviously anti-inflammatory and the food for our colonocytes. So when that is on the short side, it's not favorable. And we want to be doing everything that we just spoke about to address that gut dysfunction, the gut dysbiosis, build it up again. And this will be an end result of everything that you do upstream, because this is a downstream product. So that's excellent, Teresa. Okay, so we finished with the stool analysis. We're going to move on to the organics. So this organics comprehensive. Again, with this report, this is probably one of our favorite reports because it goes into so much detail into different systems. This is the summary. The summary, you're just going to see a lot of borderline highs, a lot of highs. So here we're going to be looking into those different systems and connecting it back to the timeline, to the genetics, to the stool sample, to the labs, and understanding what's happening. So again, just reiterating that as functional medicine practitioners, we really want to be developing a new way of thinking. When we understand the metabolic pathways, the genetics in more detail, then we're getting to those underlying root causes. We're not just symptom suppressing. So the first area that we're going to look at here is all our substrates moving into the mitochondria. So this is the energy part of the body, vital area. And we're going to be looking at fatty acid metabolism. On the whole, this is actually looking pretty good. So there's nothing really to comment about there. However, when we look at carbohydrate metabolism, we do see these all on borderline high. So, Teresa, what are your thoughts with carbohydrate metabolism?
This goes back to all the B vitamin issues, right? So, and what comes up too under L-lactate is low CoQ10, I think. But mostly the B vitamins, yes?
Correct. So as far as cofactors go, the necessary cofactors to move pyruvate to acetyl-CoA into the Krebs cycle is going to be B vitamins. Lactate to move to the electron transport chain is going to need CoQ10. However, when we do have pyruvate borderline high and lactate borderline high, it's a symptom of hypoxia. So that hypoxia can then be very connected back to the lung cancer because it thrives obviously in a hypoxic environment. So we want to be thinking of interventions that, again, we can improve that hypoxia at a deep tissue level. And what do we need to do to help that? So we got to be looking at, okay, what forms of exercise can we do? What can we do to improve the blood barrier as far as vasculature? Do we need to get more nitrates in? Do we need to get reduction in inflammation in any areas of the body? So whatever would block oxygen getting to deeper tissue, that is going to be a necessity to bring both of these back down. Yes, we've got to get those cofactors in, but this may be that indication. There's also a great product from Cellcore called hydroxygen, and that is a covalent bonded oxygen that releases only in deep tissue. So that may be a really nice product to use, and you could actually nebulize that in. So it's a product that they've actually tested with patients that are, say, COPD, reliant on oxygen. And when they nebulize them for 20 minutes with that, they don't need their oxygen for the whole day because their oxygen saturation levels are so high because of those covalent bonds. Very interesting. We use it for our athletes as well. just so that when they're at a hypoxic level, that oxygen only releases at the right time when it's needed. So very, very interesting product.
It's interesting that it was actually thought that I was having asthma when I had the lung cancer. I didn't know I had lung cancer, so they were trying to treat me with albuterol, and I really had a hard time because I ski, and so when I go skiing, I started having a very hard time when I was up in the mountains. So that's an interesting. I didn't know I had
Interesting.
cancer at the time, but so it'll be interesting. I didn't go last year, I had surgery and everything, but it'll be interesting this year when I go because my breathing, I have absolutely no wheezing anymore, but I was wheezing with the cancer.
With the cancer, yeah. Yeah, and we've got to think of paradigms as well. So, it's where on the paradigm is that functional threshold and what can we do to optimize it again? So, cancers obviously can be developing over decades. What can we then do to just optimize all these numbers to put you into a better direction so there isn't that relapse? So this is just giving us that indication, first of all, of the hypoxia tendency here. Might be worthwhile doing, the new Aura ring, the Gen 3 has actually got an oxygen saturation in the ring as well. So that might be worthwhile looking at. And they're bringing it into the app in 2022. And then you can look at your O2 sats at night pretty easily. So the next thing to think about, again, related back to cancer, is mitochondrial function is fundamental. And what we're seeing here is also a high trend. So a high trend on the Krebs cycle is telling us that it is inefficient. When it is a high trend, it can be a combination of cofactors or SNPs. Either way, we need to see what we can do to improve cofactors. Cofactors could be blocked by things like heavy metals or any toxins. So this is going to be a great retest, say in 3 to 6 months, to see have we corrected this. But again, looking at our B vitamins, we'll look at B vitamin status lower down in the report here, CoQ10, magnesium, lipoic acid, all of those are going to be key factors.
And again, the amino acids here, right?
Amino acids, and we know your proteins are low, so your amino acids, essential amino acids, I'd be doing at least 30, 40 grams a day of essential amino acids.
Well, that's a good point, because I've been doing I think I've been doing about, between the powder and the pills, probably 18, so I can go up probably.
Yeah, you can go up without a doubt. So let's have a look here. So this is going to be our B vitamin marker status, so B complex vitamin markers. And here we're going to see some high markers here. So this is confirmation that the B vitamin status is compromised. It's going to be a lot to do with that gut dysbiosis. So we need to be resolving gut dysbiosis, but we need to look at what we can do to get B vitamins in. If they're not absorbing well through the gut, we may need to look at sublingual. We may need to look at topicals as well and have a look. These first three are generally our lower B vitamins. Xanthronate is going to be our B6 level. The B6 level is non-detectable here. So that's pretty interesting as well, is just non-detectable. Doesn't mean that you aren't getting any in. It just means that this metabolite is not coming through, and it's definitely worthwhile doing other labs to see what you can do. This is biotin on the high side, telling us again that there's an insufficiency due to this specific amino acid coming through. And then we're looking at methylation cofactors. So methylmalonate is going to be our folic acid status. This is at a 50th percentile, which is ideal. Again, we need to take this with a pinch of salt because we're not sure if methylation is working properly or not. We'll look at glutathione status now. Figlu here is B12. Sorry, I'm saying this all wrong. This is B12 status. This is folic acid. And so folic acid, remembering back to our MTHFR, being homozygous on the 1298. So this is telling us if you're taking B vitamins now, you're not taking enough of that. And sometimes even 800 micrograms.
Right. I was going to say, not only that, it's that I eat a lot of vegetables, a lot. Like I eat 2 pounds of vegetables at least a day.
Yeah.
So it's not, I just need to keep doing the enzymes too, because I think that it's just not breaking stuff down enough.
Yeah. Exactly. So that's why we need to be testing. Otherwise, we're guessing.
Right.
So that's a great point there. So B vitamins are a big necessity there. We need to just retest and see if we're getting those right. We're going to go to neurotransmitter metabolism now. We're looking at vanilmanolate. This is epinephrine turnover, homovanillate. This is dopamine turnover. What are your thoughts here between the two, Teresa?
They seem to be looking okay for now.
Yeah. Yeah, on the whole, these are around the 50th percentile, so no real concern. It's telling us there's enough tyrosine coming in. You've got enough energy as far as that adrenaline goes, so that's good. We do have a high on the hydroxyindole acetate. Do you remember what that's about?
One of the other neurotransmitters, serotonin.
Correct. So when we've got a high serotonin turnover, what can that indicate?
My thinking is that there isn't enough serotonin, so why am I dumping it is the issue. Is that what you're asking? Am I dumping it, or am I just not making it?
Yeah, so often what happens when there is some gut dysbiosis, you've got high serotonin turnover. So this is really telling us that that's what's happening there, because as we go lower down in the report here, we're going to see more confirmation of the gut dysbiosis. So this is just connecting the dots back to that.
Turnover meaning that it does make it, but then I'm actually disposing it rather than using it. I don't know what you mean. Yeah. Okay.
Yeah, exactly. So this is a tryptophan. Okay, so then we're looking at oxidative stress. These on the whole, so this is interesting, again, why we've got to take everything with a pinch of salt, because these are at the 50th percentile. MSQ is 18, but we do know that these will drop when we don't have enough protein. So if we've got enough protein, does that mean that these are going to lift or not? We don't quite know. But again, it's just developing that thinking to not necessarily say there's no oxidative stress. We've got to be thinking more on a deeper level, the root cause, the metabolic pathways. So on the whole, there's no red flags here, but we need to just keep in mind that as protein levels drop, these actually on the paradigm drop as well. Okay, coming to detoxification indicators, this is a big key area to look at. First one that we're going to see on the high end is glucarate. Teresa, any thoughts on the glucarate on the higher level?
Well, it's related to glutathione, right? And a need for more support there.
Yes, so glucarate is related to glucuronidation, which is part of a phase 2 detoxification through the gut. A lot to do with xenobiotics, estrogens, anything on the toxic level that needs glucuronidation as far as phase 2. So when this is on the high level, it can again just tell us that there's some gut dysbiosis and you're spilling out a lot more glucarate than we should be. So that is key there. Then you're quite right. Hydroxybutyrate, pyroglutamate, sulfate, these are our glutathione statuses. So when we do have them at this particular pattern, this is a glutathione phase 2 depletion. So this brings us all back to the genetics, to methylation, looking at those homozygous 1298, the MTHFR. We're looking at the COMT, all of those methylation genetics. Are they really working effectively? Thinking back to homocysteine at 7. Homocysteine at 7 is great, but it doesn't say that methylation is working appropriately. Here, it is telling us that there is oxidative stress that is not being balanced. So even though we have oxidative stress here that seems balanced, glutathione status is telling us it is not. When we look at FIGLU here, it's telling us there's not enough folic acid. So when we don't have enough folic acid, we know methylation is not going to be working properly. So that's why things don't add up to say, okay, we have methylation in check. It's not in check. And the main reason is that glutathione status, which we're seeing here between 33 to 35, is at a stage 2 glutathione depletion level, high, and then we have sulfate at mid-level. So we're coming to an end now. This is the last panel we're looking at, and then we're going to wrap up. This is compounds of bacterial or yeast fungal origin. And here we're really going to see this general high trend. This general high trend is going to be telling us that there is a gut dysbiosis. Again, this is a combination of protein-loving bacteria and carbohydrate-loving bacteria. We have arabinitol, which is carbohydrate-loving, tricarbolate, and D-lactate. These are all carbohydrate-loving. These are all protein-loving. But on the whole, it's telling us there is a dysbiosis. So again, coming back to what we spoke about in the CSAP, using those broad-based antimicrobials, looking at stomach acidity, let's optimize stomach acidity, add in the digestive enzymes, and then look at a spore probiotic. Okay.
So is the thinking to use the spore probiotic after the 90 days of the antimicrobials? That's what I'm thinking.
Spore probiotic you can use before. So you wouldn't use a conventional probiotic because of the possibility of there being some SIBO here. We may just feed into that dysbiosis. Mm-hmm. But using a spore one, you would be okay. Okay, I'm going to stop sharing. So we've brought that to the hour, a little bit longer than I would have liked, but I wanted to go through that. There was a great case to go through. Thank you, Teresa, so much. Really appreciate that. Having a look in the chat if there's any specific questions. If that all made a little bit of sense or inspired you, please just give us a little heads up in the chat. It's just great to know if what we're doing is kind of helping to inspire you. And what I'd love to do quickly is just again go back to Teresa and just ask her for some of her experiences going through the foundational program, and give you maybe some explanations on, you know, what is her program at the moment, what is she charging, and how is business doing?
Oh, it's well, since I've come here, I had already started doing functional medicine, which I started like 3 years ago. Very small. I was doing 2 afternoons a week, and then sort of just trying to learn and doing hormone replacement and things like that. So, but the business part was really difficult, like trying to figure out how to run business and what I need to do, and that's all the things that I really liked about, you know, being in this program, is just you know, the marketing part, the how much to charge, the how to structure the business has all been really enlightening and helpful. And so I'm in the process right now of developing my group. I had already had a few people in a group that I had developed, and now I've added 3 new clients right now, and my what I'm charging for the group is $5,000, and if people. And that's $5,000. $2,000 of it I use for labs and for supplements. And sometimes people want to do that on their own, and it's either way is fine, but they get to know that they need to consider that that's going to happen. They're going to need some extra cash for that. So anyway, so it's been really good. It's like, I'm not leaving. I'll be around. I've still got things to learn, but it's exciting, actually.
Love it, love it. And that's the whole point of Functional Medicine Fast Track. So, you know, when we went through our learning experience, it took us many years because we had to go from webinar to webinar, seminar to seminar, and we really had to piece it together as we started with patients ourselves. And we found it very disjointed as far as getting patient results. And that's what we try and help our practitioners with at Functional Medicine Fast Track, is to be able to take real cases and start to formulate a personalized plan within a 12-week period, because that is the game. We want to get patients better. We don't want to have to go 3, 4, 5 years piecing this all together, not really knowing. And then, as Teresa said, not getting the business side right, not knowing how to actually put a program together rather than a consult to consult. Mm-hmm. Consult to consult in functional medicine is a mess. because our patients need support with all the habit changing, the nutrition. So if you go consult to consult, they're left alone, they're not supported. They need a community, they need support structure. And that is one of the fundamental bases of getting functional medicine right. And what we teach at the foundational level is how to put programs together. As Teresa said, her 16-week program is $5,000. And it's very justified. A lot of our practitioners will go $5,000, $6,000 because of the value that they add. And what that means is you can start to work with fewer clients at a higher level, get results for them, and be able to not waste any of their cash moving on beyond that. So very important to start to understand that functional medicine is amazing at getting results, but it's about getting it right. And that's on the clinical side, the business, the marketing side. And that's where you start to really see sustainability as health professionals in functional medicine, is when they have the combination of time freedom, they've got the right income, and they're getting the outcomes. That is when practitioners stick in the game. Otherwise, we have practitioners in and out of functional medicine, and then that's not doing anybody any good.
I would add that the whole piece around mindset changing has been really useful too, really enlightening. Like you do a whole section on
yeah, massive part.
Yeah.
Massive area that we never supported on as health professionals is just getting our mindset right. And that's a whole nother ball game that we address at FMFT, is just supporting everybody so that you can achieve your goals in a short space of time. So I hope that makes sense. I hope we enlightened you as far as the clinical side. They was asking, was this a typical set of labs that you would order systematically? Yes, this is the typical set would be the DNA panel, health and diet. We'd do organics. We'd do a stool analysis. We usually do CSAP ×2, and then we'd do a Dutch plus. So Dutch plus, obviously, you've got to get the timing right with that. So we don't have it at the moment. Teresa's busy doing that. And those would be our general 4 functional medicine labs. And then we'll do our labs, so normal blood labs on top of that. And that is going to give us a good foundation to put a personalized plan together, to know exactly what's happening. Otherwise, we're guessing. And as I hopefully explained here, it's not all at face value. So, if you just do a blood draw and you just see homocysteine at 7, you think everything is hunky-dory. But as you dig into organic acid, you actually see that the glutathione status is not right. And that homocysteine is then telling you, no, we need to actually look at methylation and improve it. So I think that's the joy, as health professionals, it's about a deeper thinking, a deeper understanding, not just saying, here's the signs and symptoms and here's the medication or the protocol. We've got to be thinking and understanding this process a lot deeper and better. Laura's asking, are there cases when you would consider waiting to do the Dutch plus after cleaning up a few things in the gut? Yeah, absolutely. So hormones are always the last thing that you want to address. So that is one test that you could hold back on, address everything else, and then test and see where the hormones are at. So if there are some economic limitations, that would be one test I'd hold back on, and then do that 3 to 6 months later after you've gone through and worked with the patient and got a lot of the other factors right. And then you can say, okay, now we still need to do more, or we need to top up on some hormones. Teresa, anything else that you want to add before we end off for tonight?
No, I'm just really grateful for this program. I'm glad I joined.
Love it. What would you say to anybody that's sitting on the fence as far as functional medicine goes?
Well, I mean, it's, the difference between doing functional medicine and doing conventional medicine is is light years difference. And really, functional medicine is really the medicine of the future, or present, I should say. there's no way that I would go back to the hospital. There's no way I would go to sleepless nights. There's no way to be going back on call. There's no way I would want to do that. I would rather drive Uber. um, and I would not go back to that. The stress, I remember the days of not being able to eat well, not being able to sleep, not being able to see my family for days on end. There's no way. There's no way I would go back to that. And like the health of most doctors are awful, and there's so much that I know that even the average doctor doesn't know, like around chronic illness and why things are happening. And instead of like these doctors saying, and they make up like stories, they send people away and say, there's nothing wrong with you, it's all in your head, or this is going to give you cancer if you do this functional thing, or they say some of the craziest things, and if they don't know, they should just say they don't know. I don't know what's wrong with you. I haven't been able to figure it out, period. Not, oh, it's all in your head, or something's wrong with you, or you're bothering me, or, things like that. So I would never go back to functional medicine. It's just not my thing.
Conventional medicine. Yeah.
Yeah.
Got it. Yeah. Thanks, Teresa. I mean, that's a lot of wisdom coming out there. So if any of you are curious, you want to speak to our coaches, you've got some questions, you need more clarity, then I have put a link into the chat. You can follow that link. You could book a call with our coaches, and they can certainly just set up a time with you to go through and just answer your questions and find out if this is something that you would like to move forward with or not. Functional medicine is not for everybody. And certainly it's something that you want to just think through and commit to if it is something that you want, and then do it right. For us, it's something that we would never, ever go back to our conventional ways because of the outcomes we get for our patients and the life that it has changed for us. So let alone our own health. So if you want to book a time with our coaches, it's fm-ft.com/talk. And they'll get a lot more clarity on the call with you. So I hope everybody has enjoyed this evening. Again, thank you, Teresa, for everything, for your time and for all your input and your labs. And wishing everybody a great evening. And hopefully we'll see you soon. Take care.
Thank you.
Bye.